Our last topic of this session is bleeding complications on ECMO. And I invite Dr. Venkat Goyal to present this topic. Dr. Goyal is one of the founding member of ECMO Society of India, working in the Vidyavinayak Center, Mumbai. He is past president of ECMO Society of India in 2011 and past president of Swasi in 2018. Dr. Vinay.
I went to Germany, to Berlin Heart, for mechanical circulatory support. Things were very costly, not fitting into our economy. So I embarked upon ECMO there. But that was totally new to me. And from there, I must have gone to 7-8 places in Europe and America to all these national conferences, because that is done for their staff, to learn about ECMO. And there they had a very stringent protocols and very costly ECMO that made me more disheartened. So I thought, how could annual budget of 1.25 thousand US dollars would match in our economy? Then Dr. Pranay Ojha went to Taiwan, because Mackay company was to sponsor us for ECMO machine and the training about ECMO on a ECMO machine. And there he came upon the idea that these patients are going to die. The other is also dead. So if you do ECMO and just do it on a minimum program, you will save some lives. So now coming back to the point, if we are talking about bleeding complication, what is the percentage of bleeding complication? Let us say 5 to 7% major bleeding complications. So if you minus this 5 to 7% bleeding complications by a minimum ECMO program or a minimum cost-effective ECMO program, probably you are saving or helping a 90% population. So standing between the Western Hemisphere and the Eastern Hemisphere, I found that, yes, we have to do ECMO in our given constraints with whatever facilities and limitations we have, and we don't talk of optimum things. We try to run a minimum program, and if you want to save every life and to save every bleeding episode, then you have to have an optimum program and a minimum program. So starting from there, we started our ECMO program in 2006. As a cardiologist, I had a few population of cardiac patients, and we started directly with adult cardiac ECMO. Well, that was a population with us, and we burnt our fingers. So after that, getting more disheartened in 2009 when the swine flu came, and we got a 70% success, we formed the ECMO Society of India. In this, I have some message to say. I will confine myself to bleeding complications, but the only message I have to say that I have been directed to focus on the clinical aspect of bleeding. I have to talk on incidence, I have to talk on identification, I have to talk upon the percentage of bleeding complications. But if I talk of coagulation and anticoagulation, then let me tell you one very important message. Till 2010, there has been some 50,000 articles on ECMO, of which 20,000 articles were from the Department of Pathology and Blood Bank. So those departments was working very meticulously and scientifically to see how to perfect the bleeding problems. And after that, in Europe, in America, it was a departmental ECMO services. There was a complete department, and they used to research and they used to work hard about ECMO. But when it came to Europe, it was under the leadership of our intensivists and under the ICU. So not much research work has been done. So again, with bleeding aspects, if there has been 20,000 articles, that means there is something inside it very great, which in our given limited Indian scenario, we are just following an ACT to run the entire ECMO show is just too little. So we can't talk of complications unless we have data. So that is my bottom line. So let us say about incidence. For incidence, the CNS bleed has been between 2 to 5%. The local bleed, tracheostomy, ICD, cannulation has been between 10 to 20%. And the surgical bleed, post-coronary bypass, has been between 30 to 40%. As I said, ECMO is a constant thrombogenic source in the ECMO circuit itself. And there's only one thing, heparin. Either you underdo it or you overdo it. If you underdo it, you cause thrombosis. If you overdo it, you cause bleeding. So, therefore, there is so many things about heparin itself. How to understand heparin, what is the pharmacological effects and side effects, and what are the alternatives is again a matter to perfect in itself, then to talk of alternatives. Now, as I said, ECMO is a coagulation circuit. There are so many body reactions to cause coagulation, and that is where you use heparin. And if you look at the hemorrhagic respiratory ECMO from neonates to adults, it varies between 20% to 40%, and in adults above 40%, in cardiac ECMO also. So why does the patient on ECMO bleed? He bleeds of continuous heparin infusion, decreased platelet count, decreased platelet function, consumption coagulopathy, and pre-existing problems. So what are the causes? Causes is the excessive anticoagulation, surgical processes, airway trauma, chest trauma, removal of lines, DIC, sepsis, platelet and coagulation factors, etc., etc. So if you talk of bleeding, as the topic says, it could be a minor bleeding or a major bleeding. Minor bleeding, we all tackle. There's not much to discuss about it. Of course, what in COVID, we were always wanting to do tracheostomy early, and they used to bleed from there. But initially, we were trying to control it medically with local application of other things, but we found a good cautery and a purse string sutures did a better job. So if you find bleeding and if surgery is safe, then use a surgical method rather than only medical method. Major bleeds, can we do anything? The major bleed is between 3% to 5% or 3% to 7%. Most common retroperitoneal bleed, GI bleed, and intracranial bleeds. GI bleed, manageable. Retroperitoneal bleed, sometimes self-limiting. Intracranial bleed, cause for abandoning of the ECMO program. We had 4 patients, of 60 patients we did in the COVID times, and we had to call the ECMO off. We had to abandon ECMO. Now, again, if you want to perfect bleeding in our hospitals, there has to be a very good protocol, good manuals, a well-defined investigation list, and the drugs. Now, clinical protocol, everybody knows, first treat medically, then treat surgically. If nothing is possible, stop heparin, stop ECMO. Then how to diagnose the bleeding problem? So many tests. We are not able to do them. And we are not able to do them repeatedly. That is very important. So if these are the armamentarium of coagulation techniques, and there are so many things in machine and the laboratory, and they have got so much analysis behind it. Now this is one of the protocols from National Children's Hospital, Ohio, one of the best protocol I've seen in many of the centers. They have divided investigation of a bleeding patient into level 1, level 2, level 3. Level 1, you see all those tests, a fibrinogen test, a factor 7 test, a factor 10 test, 25,000 rupees, every 8 hourly. I wondered that if laboratory investigation is to cost my patient 1 lakh of rupees per day, then how is the ECMO program going to sustain? In level 1, when the bleeding is less than 5 ml per hour in a pediatric patient, this is the battery of investigation they do invariably to come to a conclusion. We get it done hardly once a week, if at all. In level 2, when the amount of bleeding is between 5 to 10 ml per hour, these are the tests every 6 hourly, and they follow it. In level 3, when the amount of bleeding is more than 10 ml per hour, they do these tests every 2 to 4 hourly. So then they can talk about data, and then they can talk about evidence. We just go clinically. But whatever it is, we are in a different world. We have to go clinically. We cannot go by this. It is an assumption, and we have to work with jugglery. It is a gamble. Then, if at all, heparin, as you all know, all the effects, time is short, so I'm going fast through the heparin effects. The unfractionated heparin, still the time-tested and most widely used. And then the heparin managements, and how to control the bleeding if the patient is on heparin. So you have to give all those factors and try to replace the blood products and everything. That is how the best thing you can do once you are faced with a bleeding problem and you have to manage it clinically. There has been other side effects, heparin-induced thrombocytopenia, heparin resistance, and all those things. They have their own flow diagrams. You follow them. We are doing it also with some success. Then there are alternatives. Then there are alternatives to heparin also, but they are still not even 2% being applied. We are still, since the last 50 years or more than 100 years, still banking on heparin. Then heparin bonded circuits. All these things are available to us other than heparin. Now, that is what it is. India, practical management of bleeding. Don't talk of science. It is a clinical judgment. The drugs available are tranexamic acid, amicar, apritonin. Of this apritonin I have not used. Other two things are being used. You also use it. I don't think so it works with endocavity bleed. It might work with local bleeding or superficial surgical bleeding. The cascade pathway of tranexamic acid, the doses, the clotting cascade of amicar, and the doses of apritonin. Then factor 7A, very costly, goes to 70,000 rupees. So again, becomes impractical. Then talk about the surgical aspects. There's a hemorrhage at the local cannulation site. You do compression, you do purse-string suturing, you use gel foams, you use a fibrin glue, works. Then good cauterization, ligation of bleeder, hemostasis, electrocautery, judicious use of platelets and FFP, and other drugs. GI bleed, give H2 receptor blockage, gastric coating of sucralfate, injection octride, gastroscopy, further interventions, mesothelic angiography, and coil embolization. Pulmonary hemorrhages, thoracoscopy, tracheostomy, cryoablation, and alternating in alternatives of ventilator settings, etc. Intracranial bleeding, just medical management. Not much work has been done upon decompression surgeries. So basically it comes down to either stopping heparin or discontinuation of the heparin therapy. DIC, it is basically sepsis. So conclusion, despite ECMO experience, evidence-based guidelines for anticoagulation management is still lacking. Heparin is the cornerstone of anticoagulation during ECMO, but other alternatives are there. Classical tests may not be accurate enough for heparin effect monitoring. And endothelization of ECMO surface circuits are awaited. An urgent need for well-conducted research on platelet and other coagulation factors is required. Thank you.